exercise medicine. David has prepared something for us, especially today, that is contained. He is going to talk us through the latest developments in sport and exercise medicine, as he sees them, and possible implications in the future, including an update, and it's such an important one, of course, on point-of-care testing, including COVID-19 testing, and the protocols that will impact approaches to optimising athlete care in future. Dr. David Hughes, I welcome you very warmly from here in Sydney to where you are. I know you are standing by, and I throw now to you and invite you please to lead this next session of World Class to World Best.
Thank you very much, Sam. Good morning, everybody. Today I'm going to talk about a couple of areas of sport and exercise medicine where there have been significant advances in recent years, and where I think over the next decade we're going to see that they have a significant impact on how we approach illness and injury in athletes. So the areas I'm going to discuss are somatosensory function. What is it? How do we objectively measure somatosensory function? And what is the evidence base for these objective measures making a difference in the sporting environment? The other thing, as Sam mentioned, I'm going to talk about is advances in point-of-care biomedical testing. COVID-19 hasn't had many positives, but one of the positives we've had is in technology, hence the possibility for this form of conference, which wasn't very common 12 months ago. But in the other area of technological advance has been around point-of-care biomedical testing, and I think there's huge relevance there for the sports sector. So somatosensory function, what is it? Well, it's the system by where our central modulating areas in our brain are able to receive information from the periphery. So from our fingers, our toes, our joints, our ligaments, our skin. And that information allows those higher centres to inform us about where we are in space. If you're sitting wherever you are now, you can move your feet under the desk without looking at them and know precisely where they are at any time because of those signals coming in from the periphery. When you drive a car, you don't need to look at your hands, you don't need to look at your feet to see how to operate the car. Some of it obviously is through training, but at all times you are getting signals from your feet, from your hands, and from the fingertips and the skin about what is happening, and that allows you to drive that car safely. So sensations such as position, vibration, fine touch, pain, temperature, and gross touch all come into the higher centres. And it's very important that all parts of the chain are working appropriately. So you need to have the sensors in the periphery working. You need to have the nerve cell tracts in the body and spinal cord operating optimally. And then you need to have the higher centres also operating well. So if you had a condition like concussion, anybody who's ever had concussion knows how difficult it is to then perform tasks that require agility because the centres in that circumstance are not working appropriately. Let's talk about somatosensory function in astronauts for a moment. I think many of you will be familiar with the vestibular system in the middle ear, and there are many parts of the vestibular system: the cochlea, the labyrinth, the semicircular canals. And anyone who has had labyrinthitis, which is a viral condition, will understand how important it is to have this system operating normally if you want to function. Because if you've got labyrinthitis, you'll sit up in bed and have this sensation of the whole room spinning. You may feel nauseous. People are often simply unable to get out of bed because they feel so disoriented and are unable to maintain their posture. When astronauts go into space, it's a gradual decline in vestibular function. So astronauts in space lose sense of balance and their spatial awareness. And obviously, if they're performing really complex tasks, a spacewalk where they're having to repair machinery. These are mission critical tasks, and they require good sense of balance and good spatial awareness. So what happens in space is that the body tries to upregulate somatosensory function to compensate for that loss or the decline in vestibular function. Now, all of these things, if someone's doing a fairly short trip up to space, going around the Earth a few times and coming back, there are minimal impacts. But of course, I'm sure many of you are aware that NASA and other bodies are starting to looking very closely at the moment at very prolonged space travel to places like Mars, and how we allow astronauts to continue to function safely is an issue of significant importance to those who are planning those missions. And of course, if we then go to athletes, I think it's evident to everybody on this call that having highly developed somatosensory function is absolutely crucial to athletes performing. Athletes in sports like diving, gymnastics, basketball, where athletes are in the air, off the ground, not in touch with any physical object, but while they're in the air, they have to move their body in a certain complex way and know at all times where their feet are, where their head is, which way their body is moving. Clearly, somatosensory function is a critical part of high performance in this sort of environment. We know from research that has been done that somatosensory function is negatively affected by, I mentioned already, mild traumatic brain injury, so concussion, and that's because the central processing units are not working appropriately. But where there are things like chronic training overload, pain from musculoskeletal injury, so really pain from any force, inhibits somatosensory function and disturbs sleep patterns. All of these things compromise somatosensory function and therefore will compromise athletic performance. We know from some recent studies that if you look at objective measures of somatosensory function, there is a correlation between those poor levels of somatosensory function and future injury risk. One of the great challenges around somatosensory function has been the difficulty in being able to objectively measure. And we've had some crude methods that we've used clinically in the past around balance tests, etc. But balance in itself involves lots of different systems, and it's only recently with the development of what's known as the Ammeter Device, or the Active Movement Extent Discrimination Apparatus, much easier to say Ammeter, that we've been able to get some objective measures of somatosensory function. So this athlete, you can see, is standing on a platform. The larger plate under the left foot is movable, and it swings around an axis aligned to the long axis of the foot. The extent of the movement is limited by a cam that rotates around and provides some stopping points, and it creates 5 different movement extents. So we occlude the vision of the athlete, and then they're asked to move their ankle into inversion until a stop is reached, and then return it to the starting position. And by changing those stopping points by known amounts, the effectiveness or the ability of the athlete to judge how much they've moved and how much they have to move back to come back to the starting point gives us an objective and measurable idea of their somatosensory function. So what is the relevance, though, of these objective measures of somatosensory function in the sporting arena? As I've already mentioned, we know that somatosensory function is affected by injury. So if we do baseline objective measures of somatosensory function in particular athletes and then follow them prospectively, if they suffer an injury and we measure them again, we very reliably see a drop in their somatosensory function scores. There have been studies with field hockey players that have shown an association between these somatosensory function scores and injury, and have demonstrated an ability to actually predict injury prospectively. There are also some very interesting studies working with coaches and athletes to demonstrate that the higher the somatosensory function score in a particular individual, the more likely, or in an athlete, the more likely it is that a coach is to independently rate them as having had good game performance, and the higher their level of competitive success is likely to be. So where do we think we're going to go in the future with this device and the ability to measure somatosensory function? We are at the moment working with AIS COE squads here, doing research where we are developing athlete performance prediction thresholds. So where we measure athletes prospectively as part of a screening procedure, and then follow them and see how those scores affect their performance going forward, and if they're to predict performance, and also how it impacts upon their future injury history. So we're continuing to fine-tune those thresholds for pre-injury clinical assessment. We're also looking at the development of new tools and protocols for optimising athlete sensory function for performance enhancement and injury risk reduction. So not only are we saying this device can give us a score, which may then tell us something about the future, but we're saying if the athlete has a poor somatosensory function score, the device can be used to actually train them and improve that score, and we hope thereby modulate their risk factors for future injury. Obviously, when you look at that device there, it's still a fairly chunky unit, and it's quite heavy, and so there's a lot of work going on to develop a more compact and easily transportable kit. I should just mention before we move on here that this device has, the development of this device has largely been led by the AIS University of Canberra, Professor Gordon Waddington, who's really got a great deal of expertise in somatosensory function and how it affects athletes. I mentioned earlier the very high level of relevance that this has for space travel. And Gordon has been working very closely with NASA on using the Ammeter Device as a tool to assess, prevent and rehabilitate somatosensory function in astronauts on long-stay space flights. And I just learned in the last 24 hours that ABC Catalyst will in fact be their program tonight is going to be on long-stay space flights and the effects that has on the human body. And I think that's going to feature some of Gordon's work. So if you want to know more about this, please make sure you tune into that tonight on ABC TV. The next area I just wanted to touch on was point of care biomedical testing. So this photo you're seeing here is what a pretty standard city-based pathology laboratory looks in any city in Australia. You have a lot of big chunky machines, very complex and expensive machines. You have a lot of people working there, and you can imagine there are thousands upon thousands of samples of all sorts coming into this laboratory from, say, general practices and other places around the city, being processed and then going back out to the providers. And so, for many of you, I'm sure your experience of having blood tests when you go to see your general practitioner is that you get a referral form, you go to a pathology place, and the next day or two, whenever you can arrange it, you have the bloods or urine samples, whatever it is, taken, and then at some stage in the future, maybe in a few days, you'll go back and see the GP, or the GP will give you a ring and you'll get the results of the tests and be told what it means that you need to from there. But there's a growing demand for diagnostic tools that have a range of enhanced analytical characteristics, and those are sensitivity, for starters. So sensitivity means that if you have this particular condition, this device will pick it up. It will actually diagnose it, so it's sensitive to the presence of that condition. They have to be selective, and so selectivity is around ensuring that if this device says you have this condition, it's definite that you have this condition and not, one of 5 other conditions. So it has to be very selective for that precise condition. It has to be affordable, because if it's not affordable, a lot of organisations and in the sporting sector, a lot of sporting teams could not use that machine. It has to be portable, and I think clearly particularly in the sports sector, where we're always seeking things that are portable, because we're an industry where teams travel a lot across state borders and across international borders. And if we're going to provide optimal healthcare for our athletes on tour, then these devices have to be portable, and we want quick response times, because often waiting for 3 or 4 days to get results just isn't going to cut it in a high-performance environment, particularly, say, at a benchmark event like a World Championships or an Olympics or Paralympics. Just a couple of examples here of what I think of the simple examples of really great point-of-care tests that have been around for a while, widely utilised, very reliable. They give power to individuals to take measures that have a significant impact. Obviously, pregnancy has a significant impact on the health of an individual. Blood glucose also, particularly for diabetics. And so these two devices are just great examples of point-of-care devices where individuals can measure something themselves, get a result, and then take appropriate action for their own health care on the basis of the results of those tests. And the pregnancy test that I just showed you there was an example of lateral flow technology. So lateral flow tests are simple, cheap, and generally show results in about 5 to 20 minutes. The basic structure is as per the diagram you can see here, where there is a sample pad, and someone provides a sample of some sort of fluid onto that pad. It is then drawn along horizontally along the pad and past the conjugate pad, where, depending on what test you're conducting, there will be some form of nanoparticle labelled antibody or some other high-tech structure there, which interacts with the sample and then gives a test result of that test line. And there's generally a control line there as well, and the control line indicates that the test was successful and is valid. And these tests can use a whole range of different fluids, such as blood, urine, saliva, and sweat. And by combining novel technology methods with nanotechnology, which is a lot of medical tests are going, there are a whole range of new devices that are being used, that have been developed utilising lateral flow technology. And it's not just for people to use at home, and in fact some of these are best conducted by clinicians for various reasons, sometimes to do with the accuracy of the sample collection before the test is used. But these tests are increasingly being used by clinical laboratories, hospitals, general practices, etc., for delivering quick tests without quickly available information on these particular conditions without having to go through the rigmarole of sending someone to a pathology laboratory and all the rest of it that we just discussed. So the relevance of this in the past 12 months, of course, has been COVID-19, and we've seen lots of things in the last 12 months happen in record time. And we're all familiar with PCR tests, and probably I suggest the majority of you listening on this call have probably had a PCR test in the last 12 months. And obviously you have to go somewhere to have that done. And there's been a constant pressure to find other tests that allow us to perhaps diagnose or exclude COVID-19 in a more timely fashion. So a lateral flow rapid antigen test has been developed. There are actually several of them on the market, and a few of them have been approved by the TGA for initial use, although there are quite a few sort of stipulations about how and when they should be used, and there's a lot of post-market testing going on to validate their accuracy. It's important to point out that these are not the be-all and end-all, and I know there'll be a lot of people listening to this presentation who are contemplating overseas travel and are thinking, how can we keep our athletes and coaches and other support staff safe while we're travelling in high-risk areas? And it's important with these lateral flow or rapid antigen tests to understand swabs in the majority of cases, and a lot of studies have shown that if you get people to perform their own nasal swabs, they don't consistently do a good job. And it really does take someone with some, at least rudimentary medical training on how to take a good positive swab to make sure that the sample that you're using in the first place is the sample should be. These tests do have a lot of benefits. A positive test is reliable and should trigger isolation and should ensure that the person who has a positive rapid antigen test result goes and has a PCR test for confirmation, but they should be isolated until that result comes back. But more often than not, a positive test means you do have COVID-19. A negative test is not as reliable. One reason is just it's dependent on the quality of the sample that's been taken, and the test itself, even if you get a good sample, it's very time dependent, and it depends on exactly where you are in the incubation cycle of the virus, the SARS-CoV-2 virus, and so it is possible, and it's well recognised. False negatives are quite an issue with these particular devices. One way to get around that is to do more regular testing. So in the ideal situation, if you were travelling with a team and using this sort of technology, you would do this test on a daily basis. And if you were doing it on a daily basis and getting negative tests and were asymptomatic, then that's a pretty good indication that you actually don't have COVID-19. If you're only doing this test once per week, it's a lot less accurate because a one-off test in itself, a negative is not necessarily that reliable. As an example, in the UK, they bought hundreds of millions of these devices and rolled them out through schools with the idea that kids at school were going to be tested daily, and this would mean that they pick up a whole lot of cases of COVID-19 and were able to obviously control the pandemic better. Unfortunately, they got so many spurious results because they didn't have trained health professionals taking the samples and performing the tests that it was abandoned after a period of time because there were too many inaccuracies. So I suppose in summary on lateral flow technology, I'll just say it's a technology that's advancing quickly. Already, we do have lateral flow tests looking that test for COVID-19. They can be useful, but they have to be used properly. So I think the message I just want to be clear about is it's not the sort of thing where you can go, I just purchase a whole bunch of these and throw them in the bag when you're going on tour and have people test themselves, or have someone taking samples who's not trained in taking appropriate samples and hope that this will save you. They do have to be used properly. So if you're going to use these devices, it's really important that you take advice from your chief medical officer or others involved in your organisation who can provide that advice. But I do think that not just for COVID-19, but for a range of diseases, we're probably going to find that in 10 years from now, these devices are part of the travelling team's medical kit and can be used to diagnose illness on tour without having to rely on the local pathology devices. So the next thing I just want to move on to is PCR tests, which again we're all very familiar with. And PCR tests are of course the gold standard for detecting COVID-19, but it's important to remember that PCR tests were around for quite a long time prior to COVID-19 coming on the scene. They've been used very commonly in medical practice for at least a decade, and the effectiveness and precision of these tests has increased over that time. So prior to COVID coming on the scene, we would very commonly here in AIS medicine, we would order a test which we would call a PCR multiplex test. So for someone coming in with a respiratory infection, we would take a high swab and send this off, and this utilises a cartridge which looks for, say, the top 10 or 12 viral pathogens that might be maybe that could possibly cause this respiratory illness. And I suppose this is the real value in PCR testing. It gives us precise information about the pathogen that is causing the illness, and by doing that, it allows much more targeted treatment of that individual. So, if we think about respiratory illness, if we do a PCR test, we don't just find out whether someone's got COVID or not. We can look across the whole array of respiratory illnesses and find out what that person has got, and it's very useful, because if we find out they've got rhinovirus, which is what you might think of as a garden variety upper respiratory tract infection, we might be able to say to that person, listen, yep, you've got rhinovirus, you probably should stay away from your teammates for 24 hours or so, but you should be over this pretty quickly, and this shouldn't interfere too much with your training or competition. Now, if you compare that, say, with influenza, where people become very sick and it's very infectious and it could affect the whole team, that's a really important piece of information. So knowing that someone has influenza or COVID, which obviously is a serious condition, is a very different scenario to knowing someone has rhinovirus. So it allows us to take different action based on knowing that precise diagnosis. In a similar fashion with gastrointestinal illnesses, many of you will have heard of norovirus. Norovirus is the virus that brings cruise ships to a standstill. It's a terrible gastrointestinal infection, which is very, very infectious, spreads very easily through groups. And if you're in a sporting setting and someone has norovirus, you want them out of the environment ASAP. So again, if someone comes in with a gastrointestinal upset and we do a test, if we find out they've got rotavirus, which is a virus not very pleasant, but usually it's short-lived, and usually they get over it pretty quickly. That's a very different prospect in terms of how we would manage that athlete compared to someone who's got norovirus. But when it's used in a general practice setting, again, the PCR sample is generally taken, and this is how we were using it prior to COVID, and then you'd send it off and get the result back in 24 to 72 hours, which obviously is not ideal when you want to make instantaneous decisions. So this machine is called a BioFire machine. It's about the size of a shoebox, slightly bigger perhaps, pretty heavy. It's a pretty solid machine, and this is a portable PCR testing machine that can be used at point of care, and the turnaround time for getting the result on a sample is about 1 hour. It does require a skilled technician to use it. There are very distinct steps that you have to go through in terms of preparing the sample and then placing the sample in the machine. But again, it works on a system of cartridges where the cartridge is loaded up with a bank of I suppose testing the most common respiratory or gastrointestinal, depending what the issue is, pathogens that are likely to be causing that condition. It can only process one patient at a time, so a little bit slow. If you had an outbreak, it would be a bit slow, but still a 1 hour turnaround gives you a lot of information very quickly and allows you to really tailor your treatment to that athlete or individual. But it's also pretty bulky. Like this is the size of a shoebox, but obviously it's a piece of it's a precise instrument. It has to be protected if you're going to be throwing an aeroplane. It has a lot of cartridges and other equipment that comes with it, as you can see here. And I'll just mention Dr. Matt Mooney, who's one of our doctors at the AIS. He's an industry PhD student who started working with us, I think, in the middle of 2019. And he's doing his PhD in infectious diseases in athletic populations. So remembering that Matt started this PhD before we knew anything about COVID, it's certainly been an interesting ride for him, having this focus on infectious diseases when we have the biggest pandemic the world's ever seen. But Matt has deployed the BioFire to a range of locations with a number of different sports, and I think you can get an idea just from this photo of it's not a small exercise. Like that big black box there is mainly foam, and the BioFire goes and sits in the middle of that foam, keeps it very nice and secure and safe. If that stops it getting damaged in transport, and then there's a couple of suitcases which Matt fills up with other equipment, disposable equipment that goes along that is required to utilise the PCR machine appropriately. So again, I just want to, I suppose when I'm presenting this, I think it's a really exciting development, but managing expectations, it's not a small thing to take this on tour. It's not something that anybody can use. Someone has to be technically trained to use it. But once it's set up, and this is in a hotel room somewhere where Matt was, I'm not sure exactly what location this was, but once he's got set up, he's to go then, and any illness presents in the touring group can be diagnosed accurately and can be the treatment can be tailored. Great example here was the Games in Samoa, where Matt deployed with this device, and looking at, say, what respiratory samples he found. Top 3, coronavirus, OC43, nothing to do with COVID, garden variety, upper respiratory tract bug, same with rhinovirus, enterovirus and RSV. So in those situations, those athletes advised, okay, look, you're unwell, this is the bug you've got, we need to take make you don't infect other people, but really you should be feeling a lot better in a very short space of time, and we just need symptomatic treatment. There were 2 cases of influenza A, which could have completely wiped out those individuals in terms of the tournament, in terms of their own health, but also ran the risk of infecting others. And Matt was able to diagnose them early when they had fairly mild symptoms, and start antiviral treatment and isolate them from others and allow them to recover much more quickly than they otherwise would. So stop the influenza progressing. There were 9 symptomatic gastrointestinal illnesses that presented, and there were different pathogens there: E. coli, Salmonella and Giardia, all of which you've probably heard of, but they require slightly different treatment. So again, Matt was able to direct the treatment to the bug. Just checking. Yep. So in 2020, so just prior to COVID, this is what the Australian Open used to look like before COVID. We deployed to the Australian Open as part of the medical team there, and we took 2 BioFire devices. And just again, another great example where 2 days, and so essentially everyone presenting with a viral illness, we just had these operating out of a cupboard. We could take samples and have the athletes tested. In the majority of cases, they just turned out to be garden variety bugs that weren't likely to cause any major concern. But 2 days before the main draw, 2 separate athletes presented with influenza. They had mild symptoms. They didn't think they had anything major. Both of them had influenza. Again, normally would expect these athletes to deteriorate and become too sick to compete, but because we picked it up early and were able to identify the pathogen, we're able to hit them with antivirals. Both played within 48 hours. Both players pushed very deep into the tournament, and both significantly increased their world ranking in tennis. So for those athletes, these machines delivered great benefit that really changed how the tournament panned out for them. So what about for Tokyo? We would very much like to deploy these devices in Tokyo. We think they could be of great benefit to the Olympic and Paralympic teams. Upper respiratory tract infections are usually the most common presenting complaint during an Olympics or Paralympics. Differentiating garden variety upper respiratory tract infections from COVID-19 is going to be a critical, it's going to have a major impact on how our teams go in Tokyo. Obviously, there are some sensitivities around us going from a situation where we've been testing for fairly standard garden variety respiratory infections and testing for COVID. There's a lot of paperwork to go through, and so we're working on that at the moment to try and ensure that we have approval from the relevant Australian authorities to do testing for COVID before the Olympics and Paralympics. To be clear, we would not be setting up so that we somehow replace the Tokyo public health institutions or measures. Clearly, public health authorities in Tokyo have primacy, but what would be good is if athletes are presenting with mild upper respiratory tract symptoms, we can test them, sit them in a room for an hour, have a result within an hour. And if that result comes back and says, okay, yes, you're unwell, you're symptomatic, but COVID is negative, rhinovirus is positive, this tells us that we can treat this person, symptomatically and push on and be safe. Of course, if they had a positive result, we would need to walk them down to the COVID clinic in the village and have them tested and then managed by the Japanese authorities. So these tests are all. The BioFire was purchased, I think, a couple of years ago. Already there are advances where the testing time is getting down to 20 minutes with some machines. I think, like as always, these devices are going to get smaller, lighter, faster and easier to use. And I do expect, again, in 10 years from now that PCR testing devices will be small, transportable, easy to use and part of the normal medical kit for travelling teams. So the take messages from me are somatosensory function is critical for athletes and astronauts. Until recently, it's been difficult to measure somatosensory function, but the Ammeter device has changed that, and we've already been able to demonstrate correlation between somatosensory function scores and injury and athletic performance. And I think in the future, I think we will see somatosensory function assessment become part of our standard screening and injury management protocols. And I think that synergy between the needs of astronauts and the needs of athletes is good and healthy and will deliver benefits for both cohorts through cross-pollination. Point-of-care medical testing is rapidly evolving, and as I pointed out, I think we're going to see point-of-care PCR testing become standardised in the years ahead. I'll just finish with this last slide to just remind everybody that while we all love great technological advances, machines that have flashing lights and go beep aren't always helpful, and we shouldn't use technology unless we are very clear about how and why we would use it and what it means when we get a result. And as an example, very quick example, throwing athlete recently at a major benchmark event, had an MRI of an elbow. The report on the elbow said that there was a high-grade, almost complete injury to the medial ligament. Some relatively inexperienced practitioners were telling this tearful athlete that they were unlikely to be able to compete. An experienced doc overheard the conversation and thought something didn't sound quite right and did something radical, which was take a medical history, at which they discovered that this athlete had had an injury to the elbow several years before, but had had no recent problems with the elbow at all, and had just heard that there were free MRIs at this benchmark event, so it decided to come and get an MRI just to see how the elbow was going, despite being completely asymptomatic. The doctor did something else radical and examined the athlete and found that the elbow was examined normally, and the next day the athlete won a medal at that event. So just a reminder that if technology is used inappropriately, it can actually be harmful, and I think these technological advances are great, but they are complementary to appropriate clinical medical assessment, and in my opinion they will never replace value-wise the value of appropriate clinical medical assessment. Thank you for your time.
Dr. David Hughes, thank you. There would be applause normally if we were all together in a room in Canberra in the theatrette there that I'm remembering with now, like this sort of sense of nostalgia. Who would have thunk it? And not to mention the combat room, where we don't have combat, we have conversation, usually in World Class to World Best. So fascinating to hear your insights. Thank you for delivering them in such a user-friendly manner, although I did have to say to myself quietly under my breath, sensorsomatic. Somatosensory. I don't know, it kind of rhymes with tomato. But when you stumbled on that a couple of times, when you stumbled on that a couple of times, I kind of felt a lot better. Thank you. We have a couple of questions. We only have a few minutes left before we move to lunch. But from Tim Kelly, thank you. I think it's really important that we do get to these questions with you, Dr. David Hughes. Tim Kelly has asked, can the AMEDA detect athletic talent?
Good question, and we don't know the answer to that. I suppose the best I would say is, can a coach detect athletic talent? And I think most of us would answer, yes, they can. That's what coaches are really good at. And there was one study that looked at the coach rating of performance during a match, and there was a correlation between the objective measure of somatosensory function on the Ammeter machine and the coach rated performance of those athletes. So I would say there's certainly a suggestion there, but I think that's part of what we need to look at in the future for, to see how we can best utilise the Ammeter.
I like that answer. How do you measure a coach's ability to pick talent? There's one for us in the years to come. I get another chance to give this word a go. Thank you, Kathy, for giving me this challenge. Can somatosensory results change throughout athlete careers?
Another good question. I would say almost certainly yes. We certainly believe it can be trained, and that we've seen cases of injury where where individuals' somatosensory function has diminished, and then with training it has improved. So we certainly believe it can change across their career, and we believe it can be trained. And I think that will be the really exciting piece, if we can confirm that it's predictive of injury, and then we can use the device to actually train somatosensory function and improve somatosensory function. Then really our objective is that we may modify their future injury history by improving that function.
I think we can all train ourselves in this upcoming lunch break to say somatosensory. Oh my gosh, I've had 3 goes. What does science say about trying 4 times? Somatosensory. Yep. There we go. Thank you.
Finish while you're ahead.
Dr. David Hughes, it was wonderful to connect with you today. Thank you again sincerely.